Okay, I want to say welcome to everyone. Thank you for participating in today's webinar, Breaking Down Barriers, How Family Physicians Can Advance Access in Complex Systems. With looming changes to access to care and many facing financial challenges, the work of health equity has expanded. Regardless of patient background or circumstances, ensuring all have access to health care and the ability to live a healthy life is a priority for family physicians across the country. I am Erin Yeck, the Director of Education for the OAFP, and we're thrilled to have you with us this evening. We're confident this is a presentation you will enjoy. To comply with AAFP CME requirements, it's my job to inform you this CME activity complies with the AAFP credit system's eligibility requirements and the ACCME standards for integrity and independence in accredited continuing education. All content controllers were asked to disclose relevant financial relationships with ineligible companies. And there were no relevant financial relationships reported. Neither of our speakers or our moderator have relevant financial relationships with ineligible companies to disclose. Before I hand it over, let's run through the Zoom webinar instructions to ensure that we have a smooth technical experience. As I'm sure you've noticed, all attendees entered without the program without video and without the option for a microphone. To communicate, everyone will be able to submit questions using the Q&A function located in your Zoom toolbar and message other attendees and OAFP staff in the chat box. We ask that you use the Q&A function for speaker questions only. As you're listening to the presentation, if you have a question for our speakers, please enter it there. Myself and Dr. Johnson, our moderator, will be monitoring this for the duration of the event. Please ask as we go, and this feature will compile the questions for us. If you see a question that has been asked and you'd like to have the topic addressed, please click the thumbs up icon near the question. This will upvote the question to the top. This will help keep track of the most popular questions. Our speakers will address questions at the end of this session and will cover as many as time allows. If you have any technical Zoom questions, please use the chat box for those, and OAFP staff, which is myself and Emily Pavoni, will be able to assist you. This session is being recorded, and the OAFP will be providing access to the recorded material within the next month. Joining us today is Dr. Kristen Johnson. She's serving as our moderator. Dr. Johnson is a champion for health equity and double board certified family and lifestyle medicine physician. She specializes in inclusive practice, lifestyle medicine, and education while serving the underserved. Dr. Johnson lives the phrase, "To whom much is given, much is required." Through her career path in medicine and medical education, research pursuits, leadership activities, and dedication to serving the most vulnerable communities. Dr. Johnson is currently the chair of OAFP's Health Equity Work Group and leading the charge at the Academy. Dr. Nanette LaQuesta Kimmel is a family physician based in Columbus, Ohio, affiliated with Riverside Methodist Hospital and Ohio Health. She earned her medical degree from the University of Cincinnati College of Medicine and completed her residency in family medicine at Ohio State. With over 17 years of clinical experience, Dr. LaQuesta specializes in comprehensive family care. In addition to patient care, she serves as the System Program Director for GME Inclusion and Belonging, Director of the Physician Pathway Scholars Program, and Associate Program Director for Riverside Methodist Hospital Family Medicine Residency. Dr. Robert Saper graduated from Harvard Medical School in 1988 and completed his family medicine residency and chief residency at University of California, San Francisco. He practiced full spectrum family medicine in the San Francisco Bay Area before training for an academic career through an NIH-funded research fellowship in integrative medicine and an MPH at Harvard. He then joined Boston University School of Medicine and Boston Medical Center, where he helped found the program for integrative medicine and health disparities. His research focuses on the safety, effectiveness, and implementation of integrative medicine approaches for common primary care problems, especially in underserved populations. In 2021, he joined the Cleveland Clinic as the Nancy J. and Michael F. Rosen Chair for Wellness, where he champions wellness and prevention for patients, caregivers, staff, and the surrounding communities. Thank you all for joining us this evening. We're going to begin with Dr. LaQuesta, who will then hand it over to Dr. Saper. Dr. LaQuesta, the floor is yours.
Thank you so much for that introduction, and thank you also for having me participate in this webinar. So these are our learning objectives. I'm not going to read them all to you, but overall, I'm hoping that by the end of my presentation, we'll be able to address several of these, and I'm going to spend the majority of our time highlighting the way that health equity is taught and supported in family medicine graduate medical education, and hope to inspire you in finding ways for practical application in your own practices. So, the mission is the calling of an organization, and we all have our own mission within ourselves. But the culture are the norms, attitudes, and behaviors of a group. And we at Ohio Health, we've spent the last 10 plus years cultivating a culture that supports our core values. And they're listed here: compassion, excellence, inclusion, integrity, and stewardship. And of the core values, advancing health equity supports each of these. We have a lot of work to do, but I'm proud of what we've been able to accomplish and hope that you can find some inspiration in our efforts today. I'd like to share with you some of our system-wide initiatives. When we talk about health system-wide initiatives and a strategic plan, it can't be done without a team. So this is one of the first things I'd like to point out that I think is unique to our health system is that we have an inclusion and belonging team, including the support of my boss, who's the DIO and the Vice President of Medical Education and Academic Affairs. But you'll see that there's lots of other team players there in the clinical learning environment, operations, accreditation, and student programs. And so, just the nature that we have a team to support over 425 learners of residents and fellows and over in 39 residency and fellowship programs across 5 care sites. As an independent academic medical center in any other system, you can't be successful without a team, without leadership support, and without inclusion champions throughout each of the residency and fellowship programs. So my role in itself as a program director of inclusion and belonging is unique because it's just that. The position itself is funded through GME in order to support the initiatives and the strategic plan that this team sets forth and is supported by all of the champions. So the other thing, that I hope is a big takeaway is that no initiative can be successful if it's extra, if we get it, we'll get to it if we have time, if it's not measured and it's not given time nor resources. And I'm aware that this is a big challenge for all programs and all family physicians about time and resources. So I'd like to really uh, to share a little bit about our initiative that we had as inclusion champions in order to help support this work. So what is an inclusion champion? It's somebody who helps set program-specific goals within line of the Ohio Health GME strategic plan, providing support for the initiatives, incorporates consideration to existing committees and program structures. Hint, that's another takeaway, is trying to build all of these into existing structures. And examples of that within GME might be in recruitment, competency, didactics, wellness committee. And this person or persons may have accountabilities in a faculty role that's supported by administrative time. There's a QR code up at the top there. I'll have that on the next few slides. And so if you'd like to learn a little bit more about the Inclusion Champion Project, that leads to a video that'll tell you more. So again, an inclusion champion's empowered to ask the hard questions. Is there anything we can do to make this process more inclusive? Is there anything that we could consider as implicit bias playing a role in this decision process or committee? Is there anything we are missing as an opportunity to demonstrate our core value of inclusion? And again, if we're looking at process and policy, that's where true advocacy is. You don't have to, stand with a picket line down at the State House. You don't have to have a fancy title. Asking the questions and looking in our own structures and our own circles of influence on how it is that we can affect process and policy is advocacy. And what we do as inclusion champions is challenge the status quo to advance inclusion culture. So this initiative was supported by the National Initiative 8, by the Alliance of Independent Academic Medical Centers. It was a project that we did with 29 other partner institutions across the United States, where we were one of 5 capstones at the national meeting, highlighting the impact of this work. In addition to having inclusion champions within each of our residency and fellowship programs, we have a treat. We have a reward for our inclusion champions with a time where we come together once a year where we commune and recharge, build synergy between programs, and discuss a lot of things, including our strategic plan, identify what our baseline efforts are, completing a needs assessment. Hint, that's another key in advancing health equity, bolstering the foundations of inclusion and belonging, not limited to, but inclusive recruitment practices, holistic review, and mitigating our own implicit biases. And annually, each of our programs develops an annual goal, which is tied to the culture quadrant of our balanced scorecard, which I think is also a unique aspect of the way that our organization has demonstrated value in inclusion culture by tying it to an important part of our balanced scorecard. So, what is a strategic plan? So I have an example of some of the strategic plans that we've had over the last 5 years. And you'll see our first year in 2021 when we really started writing down what these plans should be. The very basic building blocks was just identifying a champion, naming who that is, giving that role importance and elevating it. And then also, starting to acculturate what the building blocks of the foundational concepts are in order for us to build an inclusive and equitable learning environment. Over the years, we progressively advanced that role. And initially, our strategic plan was really to support addressing the diversity of our physician workforce. And the second wave of our strategic plans really focused on developing a more inclusive and equitable learning environment. And then this year, our strategic plan was really to engage in continuous improvement to identify and meet program-specific goals. Again, a takeaway point is that, every program, every office, every organization or service line is going to have its own unique culture and needs. And allowing leaders or the inclusion champions within those space identify what those program specific goals can be within the strategic plan will help motivate participants to move the needle. Identifying gaps in program-specific inclusive recruitment practices, screening and providing support for what we're referring to as the social determinants of education. We've all heard of the SDOH, social determinants of health, and those also exist in education for our learners. And so if we can provide support for them, hopefully we can also support an inclusive and equitable learning environment. And then lastly, to provide faculty development resources for cultivating cultural humility and upstander practices. So we'll dive a little bit deeper into some of these. So, from the annual survey, we look at, what are our baseline efforts and the needs assessment that we have. And we now do this annually and use the results to guide our strategic plan. Most recently, our highest engagement was in these areas, and you'll see that a lot of that that's listed here was within the strategic plan that started about 5 years ago. So you may have heard, that culture change requires 5 years in order for it to really show up as, being woven into the fabric of who you are. And I think that that's true. And where were our opportunities? Well, again, looking at faculty and resident development in 2 specific areas, looking at those social determinants of education, program-specific initiative funding, which is always a challenge, longitudinal community partnerships in order to form relationships with community partners, and then, of course, representation in program faculty and staff. So what did we do with this information of the survey? So we use this information, to guide our inclusion and belonging strategic plan. And then with our system, inclusion and belonging resources were created in order to support this resident and faculty development. And then partnering with our provider well-being team, we were able to address the social determinants of education with a pilot project where we screen all of our new learners and then connect learners with a community health worker in order to provide resources to address those SEOE. And the important parts about the connection to the community health worker is that these are professionals that are not associated with the training program, which provides privacy for the learner and also decreases any type of bias that may come from the program directors or the faculty members who are responsible for evaluating that resident, privacy for the learner from that bias as well. And then also connecting the resident or the fellow to resources. This is just a cover slide of the faculty development that we developed as a system in order to provide it to our learners. This is one of our greatest needs or requests from our programs. And the biggest takeaway about that is focusing on developing cultural humility, not making assumptions, being curious and respectful. It's the new terminology that has taken precedence over cultural competence, with an acknowledgement that culture is not monolithic. We use this framework of the 5 R's that was highlighted within the American Journal of Medicine in order to teach our faculty and our learners on how to cultivate cultural humility. And we provided cases, discussion guides, worksheets provided for on-demand use by programs. And then also faculty development support and office hours in order to help faculty and learners use this framework. And then our second gap that we identified from our needs assessment was that we needed upstander behaviors and how to advocate for yourself and others, particularly in faculty development that includes education on microaggressions, which, as you may have heard in some trainings, the parallel between a microaggression being like a mosquito bite or like a paper cut. And having one is painful or even annoying, but if you're covered with them all over your body every single day, that you can see how having those types of micro traumas, microaggressions can result in a traumatic learning environment. And so, responding to microaggressions and upstander behaviors is something that we try to provide faculty and resident development to, and how to respond rather than to react to microaggressions when our learners hear things like this. And then, what about our inclusion and belonging goals that we refer to? So all of our programs, they develop an inclusion and belonging goal, and we started that in 2023. And the breakdown at that time for our residency and fellowship programs of what the goals were are listed here. And the majority of those goals were in workforce development, again, in increasing the diversity of our programs. And again, the important thing, the special thing about what we're doing within Ohio Health is that goal is tied to the culture quadrant of our balanced scorecard, which again demonstrates the importance that our organization is allowing us by tying inclusion and belonging to our culture. And then we also support each of our residency programs in developing a SMART goal that we hope that they're able to accomplish. And by SMART, we mean specific, measurable, attainable, realistic, with a time frame. And these are just some examples of some SMART goals that programs have submitted. And again, the inclusion and belonging team checks in regularly with those programs, with those inclusion champions, in order to provide support for them to accomplish their goals, checking in with them to see if their goals need to be adjusted or if they need additional resources or people to help accomplish their goals. And then the last system-wide program that I'd like to share with you is the Ohio Health Physician Pathway Scholars Program. As the program director of Inclusion Belonging, I'm also the director of this program. And our mission is to provide pathways that lead to a physician community that reflects the diversity of those we serve. Because we know that when physicians and the patients reflect each other in their diversity, that outcomes are improved. So the Pathway Scholars Program is a competitive application process where selected medical students are matched with mentors. They're provided professional, academic, personal, emotional, and financial support with a longitudinal professional development curriculum, opportunities for community service, and exposure to our graduate medical education programs, and an opportunity for loan repayment if they match into an Ohio Health residency program. So as the program director, I direct this program, but also the administrator position. Scholar stipends are funded through our graduate medical education department, and loan repayment options are funded through GME care sites. Additional stipends are supported by foundation funds. For example, if a student wants to pursue any kind of scholarly activity, those are additional stipends they can apply for. And this program has been featured at national conferences as an innovative program for addressing healthcare inequities. And so why would a program like this exist? Well, there are a lot of things that can derail a student from, completing the path to becoming a physician, particularly students who are underrepresented in medicine. And so we're hoping that the PPS, the Pathway Scholars Program, and GME, through our inclusion and belonging initiatives and our inclusion champions, can help keep students on that path. These are some of the examples of the longitudinal curriculum for personal and professional development that we provide for the students. And in addition to that curriculum, our mentors, students, and allies provided quite a bit of community benefit to a lot of different organizations that we partner with. And it is just a wonderful way, not only for us to serve our community, but also to show our students, hey, this is the community that's waiting for you to complete your training and to become a physician, to really entice those students to stay within our community. And then I'd like to just take a few minutes here at the end of my time to highlight specifically how family medicine residency programs are well positioned to support health equity, and hope that these examples inspire you to explore ways that you can also get involved. So our Ohio Health Doctors Hospital residency program created an inclusion curriculum for their residency program with these specific curriculum objectives. And this curriculum was presented as scholarly activity and shared within the STFM network. Additionally, Doctors Hospital, they supported a newly formed community care clinic in which we were addressing high needs patients in terms of social determinants of health, and it's been very successful in meeting the needs of the community. Another way that the program has supported health equity and increasing access to not just their care, but also addressing social determinants of health, is a partnership with Mid-Ohio Pharmacy, where patients and healthcare providers, they partner together to receive a prescription where patients can visit participating food pantries throughout Central Ohio once a week to pick up fresh produce for their family. And then I just also want to point out that one of our family members that's pictured here is discussing the initiative on the news on NBC4, providing information to the community through trusted media is another way to support health equity and increase access to good information. Grant Family Medicine is our largest family medicine program housed in the heart of downtown Columbus. They've done so many things to partner with the community to increase care for women and children and to expand, women's health services and education for the community. Additionally, supporting community partners and seeking out financial support for community programs and provide community education are other ways that Grant has demonstrated the tenets of health equity and been leaders in this space. And then also, Grant Family Medicine works to expand treatment services for patients with hepatitis C and for the LGBTQ community, both decreasing barriers to accessing care. And additionally, demonstrating allyship and supporting community partners. These are outstanding ways that the program has demonstrated their commitment to health equity. Another way to advance health equity is addressing the family physician shortage in underserved areas. And this is a well-known problem that OFP has provided resource links and national state programs to in order to incentivize physicians, but to practice, not just to practice in these areas, but, the problem extends beyond physician recruitment. So, pay equity and office staff recruitment is also a problem in underserved areas. And so, Grant Family Medicine has worked hard in order to advocate for pay equity for medical assistants and develop leadership roles, and working to incentivize not just physicians, but also other support persons within the medical home to provide underserved care. And then Oblenis Family Medicine is our rural family medicine program, and they've used their all-staff team building events to support community partnerships. And residents in this program and others have also served as representatives in organized medicine and learned how to advocate for patients and medical education at the state and national level. Oblenis residents have also participated in a lot of community partnerships, providing community benefit, and visibility in the community increases awareness of our services as family physicians and builds trust. Moving on to Dublin Methodist, they have a Wellness on Wheels initiative, as do some of the other programs. But this one is particularly notable as they bring healthcare services directly to individuals experiencing homelessness and teaches important skills and tenets of patient care. Dublin Methodist Residency also initiated a school-based health clinic partnership with Dublin City Schools, which I think is a really unique way to partner with the community, in which they provide monthly primary care services at 4 different schools, offering vaccines, well visits, sports physicals directly on site. And it's particularly impactful because these over half the students in these clinics are uninsured. Another example of how to partner with the community is through a pop-up food pantry in collaboration with the Dublin Food Pantry, and also demonstrates community partnership and leadership. And then Riverside Family Medicine has a in-house food pantry, and this program was established in 2018 with the aim of addressing food insecurity in patients with diabetes. These are the inclusion criteria, and our goals are not only to provide food, but also education and address other social determinants of health in a group visit format in partnering with our community health workers. Riverside Family Medicine also has a longitudinal medical Spanish curriculum that is provided for all residents. As we know, language concordance between patients and physicians results in higher patient satisfaction, greater patient understanding, improved medication adherence, and thus outcomes. And then finally, another example over at Riverside Family Medicine is partnership with the Ohio Colleges of Medicine Government Resource Center and the Ohio Department of Health in a cardiovascular equity improvement project. And we're looking at evidence-based medicine to improve blood pressure control, statin use, and screening for the social determinants of health, particularly in our Black patients and Ohio Appalachian region. So these are just a few of the examples of ways that partnering with other organizations and can advance health equity. And I think you're starting to see some patterns here. This last case also teaches residents practical quality improvement in collaboration with community health workers at clinical pharmacy, and also how to advocate for equity and resource allocation. So in summary, I know that was a lot of information and a lot of examples, but I'm hoping that by the end of this, you can also agree that graduate medical education and family medicine is uniquely positioned to advance health equity, and access can mean more than just expanded office hours. Maybe it's expanding a skill set or reaching communities that are typically underserved, and expanding your community partnerships through community programs, quality improvement, and research collaborations, and partnering with other academic institutions. And of course, teaching the next generation of family physicians and inspiring young doctors to follow in your footsteps is going to also address the shortage of family physicians and primary care doctors, because as we know, with family medicine is the right thing at the right time for most patients. And so with that, I am going to pause. I'm going to end my slideshow here and stop sharing. Pass the mic to the next speaker.
Thank you so much, Dr. LaQuesta. That was incredibly inspiring and amazing for all the work you've done. I'm Rob Saper, Chair of Department of Wellness and Preventive Medicine at Cleveland Clinic, and a practicing family physician for 33 years. I'm going to take a moment and share my slides. So we talk often, and we were just speaking about health equity and how it applies within the educational context. And I want to introduce a very related concept, and that is the concept of wellness equity. First, a disclosure that what I share here, my opinions and views, are expressly my own and do not necessarily reflect Cleveland Clinic, my institution, Ohio Academy of Family Physicians, or any funders of my research. So, what is wellness? When we hear this term, many of us will have multiple different ideas. Some of us may think of some kind of a weekend retreat or a spa or a massage. But I want to operationalize this term in the way that we do at Cleveland Clinic to be very specific, and it's quite analogous to the CDC and WHO definitions of health. Essentially, wellness is a process. It's a pursuit. It's the active pursuit of optimal physical, emotional, social, and spiritual health. And so as we think about the whole person, we look at this diagram representing the four major domains of the human condition. And I place physical at the very center because most of our patients come to us with a physical complaint, a cough, a backache, diabetes, elevated blood sugar. But health and wellness is very much related also to what's in the lower right quadrant, which is emotional health. And that encompasses not just emotions, but mental health. Cognitive function, executive health, emotional resilience. In the left lower quadrant, we have social. As family physicians, we are educated in the biopsychosocial model, and we know very dearly how important psychosocial factors are to contributing to health and how they're impacted by health. And so certainly this encompasses social determinants of health, but it also includes the social relationships and network that our patients have in their family, their workplace, their larger community, their places of religious observance, and so forth. And lastly, the spiritual domain is an extension of the biopsychosocial to biopsychosocial spiritual model. And what do we mean by that? Certainly can incorporate people's religious observances, attendance to church, synagogue, mosque, belief in a universal power or God. However, this domain also applies to an individual who is not religious in an organized fashion. It can apply to the aspect of our lives that gives us meaning, purpose, some kind of faith that things are going to work out. And so these four domains, in and of themselves, are all domains of health: physical health, emotional health, social health, and spiritual health. And wellness is really that holistic approach that we bring in family medicine, where we are pursuing health in all these domains and they're integrated. So what do I mean by optimal? Well, our patients are very diverse. They have various abilities and disabilities. So what wellness may look for someone who is healthy, 40 years old, no significant adverse social determinants of health, may look very different than the 20-year-old with intellectual disability, congenital anomalies, and so forth. Both can pursue wellness, but of course, what optimal wellness for each person will look different, but nonetheless still be meaningful and important for them. So I wanted to operationalize and define that term as we talk more about wellness equity. So wellness equity is defined as that everyone has a fair and just opportunity to attain their highest level of wellness. Again, wellness being physical, emotional, social, and spiritual health. And this is a very much an adapted definition from health equity, where we all believe that everyone should have a fair and just opportunity to pursue their own health and health care. Many of you, I'm sure, are familiar with this diagram, with this cartoon, which nicely juxtaposes on the left the concept of equality and on the right the concept of equity. So here there's a family, a dad and his two kids, and they all have equal boxes to stand on to be able to watch the ball game. And the dad has plenty of ability to watch the game. The oldest son just barely can see it, and the youngest one has to still look through the cracks because they're receiving equal resources and support. Whereas with equity, each person is receiving the support that they need to attain, in this case, to be able to watch the ball game, but in the health and wellness sense, to attain wellness equity. Similarly, I'm sure many of you have seen versions of this diagram, and what you see here are categories of factors that contribute to wellness outcomes. And we are all trained and have done residency to provide medical care. In a very humble way, what data shows that at the population level, medical care accounts for 11% of the variance in outcomes across a population. Now, I want to make an important distinction. Each of us in our offices make enormous contributions to an individual's health and wellness right in front of us. But again, if we step back and we think about a population, one of the largest categories is an individual's behaviors, of which we counsel people on and help them on. But ultimately, these are behaviors which they have outside of the office. Their nutritional habits, the level of physical activity, or conversely, a level of sedentariness. How well do they sleep? The regularity of bedtime and wake-up time, the degree of difficulty in falling asleep or staying asleep, and then certainly sleep disorders like sleep apnea. Stress management. All of us as providers and all of our patients experience stress. That is a fact of life. Stress in and of itself is not always a bad thing, but how we're able to cope with it and manage it is. Do we have adaptive coping mechanisms, the ability to go out and exercise and work off the stress, or to be able to walk through a difficult situation with a loved one? Or do we have more maladaptive stress responses, such as catastrophizing, anger, of even violence, interpersonal violence, as a way of managing stress? Risky substance use, of course, is a behavior that contributes greatly, and I already mentioned violence. The next category in terms of percentage is the social category. And again, this is a non-exhaustive but a significant list of various social factors that influence and contribute to health either directly or very often indirectly. Race via racism, ethnicity, gender identity, education, health literacy, language, geography, age, religion, so forth and so on. Because of discrimination, prejudices, different isms, these, of course, can impact someone's health greatly. Genetics certainly play a role, but what we're learning more and more that a person's genes do not define their outcome, do not define their definite phenotype, but there's interactions between the environment and genetics, behaviors like nutrition, stress management, and genetic expression, as well as the impact of racism, discrimination versus feeling a sense of inclusion and belonging, also on genetic expression. And of course, the environment is an important contributor. Climate change is getting obviously significant attention now. Air pollution is a well-defined environmental determinant of health. quality of the soil, contaminants, heavy metals, quality of the water, and green space. This is not something we talk about too much, but being in nature versus a highly urbanized environment in and of itself can have healing properties. So this is the, not completely exhaustive, but gives you a sense of the variables that contribute to health and wellness outcomes. So wellness disparities exist in all different conditions and populations. And these are just a few of the largest and more common areas that we see these disparities, both in our communities within Ohio, the state of Ohio, the United States, and globally. Diabetes, that metabolic combination of type 2 diabetes and obesity, cardiovascular disease, which of course incorporates hypertension, CAD, CHF, pain. That's been an area of my own research quite a bit. Maternal and child health, such as preeclampsia, gestational diabetes, birth outcomes, mental health, and cancer. This is an example of some wellness disparities from my own research. Colleagues of mine from University of Pittsburgh, Boston Medical Center, Intermountain Health conducted a study where we enrolled several thousands of patients with acute low back pain, and we measured the transition of those patients from acute to chronic low back pain. So in our practices, I think many of us have been taught acute low back pain, it's a self-limited condition, keep on moving, non-steroidal anti-inflammatories, time, maybe some heat, and people get better. But actually, the transition from acute to a more chronic low back pain, which is defined as greater than 3 months, is actually significant. And so if we look at that transition here as stratified by race, we see that 30% of whites transition to chronic, a little over 40% of blacks, and then around 38% in Hispanics. When you look at high impact chronic low back pain, so that's chronic low back pain 3 months or greater, and often it's years, and high impact meaning that it impacts some of their key social or occupational functions. You see a disparity here with blacks being the greatest, then Hispanics, and then whites. Here we look at stratification according to sex at birth, and you see for chronic low back pain, white, Black, and Hispanic in that order in terms of rate of transition. But look here at women. You see that the female or women conversion of chronic low back pain, 45%, is greater than any of the different races, racial or ethnic categories here for men. And then you see a similar pattern here for men and women. So this is just one example, one condition, and we can show it for many, many others, the discordant impact, in this case, on race and gender. For some of you may have heard of this groundwater approach or model in thinking about racism and other structural determinants of disparities. It has been forwarded by the Racial Equity Institute, or REI. They conduct a number of workshops really about the history and manifestations and impacts of structural racism, which I attended, and I found it to be extraordinarily not just helpful, but truly transformative in my own personal and professional perspective. And so the model here is a person's living, in front of a lake, in a lake in front of your house. You find one dead fish, and so you see that one dead fish, and so your mind wants to analyze that fish to understand what caused its illness, what caused its death. This is very much analogous to what we do in our offices, right? As we see that one patient in front of us with a fairly biomedical approach. However, the next day we see in the lake that half the fish are dead in that one lake. And so your thinking now has shifted, and you're concerned that there is some kind of problem in the lake environment causing these fish to die. And so you analyze the lake to understand, how it's contaminated, pesticides, and so forth. But in the third scenario, on the next day, half the fish are dead in the 5 nearby lakes to this lake. And so now with this picture, you realize that, something's going on that's interactive between all these lakes, and you have to analyze the groundwater that feeds all these lakes to understand how all the lakes have this same contamination that's killing those fish. And this is essentially a model or a lens, this groundwater approach, to structural racism, structural inequities in our communities that feed the disparities that we see in our office. And this is data for African Americans compared to whites that reflects that groundwater approach of systematic inequities. So what you see here in this paper is different domains of health condition, educational attainment, criminal, legal, child welfare, and finance. So you have infant death rates, death from diabetes and health, below reading proficiency in 4th grade for education, being suspended in the first 12 years, in criminal legal, being searched on a routine traffic stop, incarceration, and child welfare, identified as a victim, in foster care, finance, denied a loan or doesn't own a home. And what you see here, the reference group here is whites. Sort of, if you think about an odds ratio, this is 1.0. And this is, in these red dots here, the ratio for African Americans to white in all these different domains. So for example, for infant death, infant mortality, about 2.3 or 2.4. Suspended in K through 12, almost 4x. Incarceration, the greatest here, 7 times. Denied a loan. So again, what you see here is the impact of historical policies, practices, biases that have impact health institutions, educational institutions, criminal legal system, child welfare, and financial systems, so that all throughout African Americans have higher rates of these. So again, that groundwater model that these prejudices infiltrate the society in all these different areas. So shifting back to health, as we spoke about in that initial diagram, we talked about lifestyle and behaviors. So right off the bat, what I want to get across here, this is a simplified linear diagram, all leading to wellness disparities. What I want to point out here is that it's not just a matter of, yes, we can help our patients eat better, be more active, counsel them on stress. If we just act at that area, which is the area that we have the greatest opportunity to, yes, that can influence disparities, but I don't want anyone to take home and say that this is the problem. These changes in lifestyle and behaviors of our patients are driven by social determinants of health and wellness, housing, education, employment, transportation, food, access to care. And the social and historical roots of these are structural racism, poverty, trauma. It's very, very hard, obviously, to address history, but can be done, not necessarily in the office. There are ways, of course, that we're all touching, and you heard from Dr. LaQuesta, interventions to try to address this. And what I'll share with you here are examples of ways within the office we can work with patients on this, while acknowledging and understanding that it is not just simple behavioral change, but some of these lifestyle behavior changes are very much formed by antecedent factors. So, in our Department of Wellness and Preventive Medicine at Cleveland Clinic, we have integrative medicine. That is the evidence-based combination of medication, surgery, and so forth with acupuncture, yoga, massage therapy, chiropractic, osteopathic manipulation. Lifestyle medicine. Our moderator, Dr. Johnson, is certified by the American College of Lifestyle Medicine. And this is a growing specialty. And I think many family physicians, we have many here, are getting certified in lifestyle medicine. And if you look into lifestyle medicine, it essentially has 6 pillars or foundational elements. And they're very analogous to what I was showing to you about contributors to health outcomes before. So it's our patients' nutritional habits, level of physical activity, how well they sleep, the ways in which they manage stress, social relationships, and connections, and then our attitudes and where we get meaning and purpose. Lastly, functional medicine has a lot of overlap with lifestyle and integrative, very much approaches the patient as this whole person, like we do in family medicine. Definitely leads with the influence of diet and other approaches to try to have the systems of the body, digestion, musculoskeletal structure, intracellular communication through our nervous system, operate in a best possible way. And so it is a systems-based approach, much like I've shared with you how our patients' health and the roots of their health behaviors are very much system related. And so when you look on the left column here, you see some of the common conditions or examples where we see substantial wellness disparities. I spoke about chronic pain or chronic back pain, anxiety disorders, obesity, headaches, depression, and overall quality of life. On the right side of the column, you have a variety of different integrative or holistic therapies, yoga, acupuncture, spinal manipulation, which can be done by chiropractors, osteopaths, and physical therapists in different ways, but a form of manipulation. Meditation, massage therapy, nutrition, physical therapy. And each of these colored lines that I've drawn here are referenced in the notes of this slide of meta-analyses or systematic reviews showing how, for example, yoga can be a helpful adjunctive therapy for patients with chronic back pain, fibromyalgia, and so forth. Acupuncture has been found to be helpful with stress and anxiety. Spinal manipulation, certainly helpful with chronic pain. Meditation, particularly mindfulness, has been found to be helpful in migraines. And this isn't just anecdotally, but these are RCTs or high-level observational studies that have been controlled for different confounders and entered into meta-analysis. And certainly physical activity for all of these things. So the evidence is there for these approaches to be of benefit. The challenge is how to implement them and what are those barriers to implementing them. And I like to describe the barriers with, I call the 4 A's: awareness, availability, accessibility, and affordability. And I'm just going to share with you, 1 or 2 examples of how these barriers manifest themselves in the context of integrative or holistic medicine. So awareness. This is a study where folks were interviewed and they were asked why they didn't use these different 4 common complementary health practices: acupuncture, chiropractic, natural products, vitamin supplements, and yoga. And what you'll see here in this 3rd and 4th category, I never thought about it or never heard of it. If you combine these two categories. For example, with acupuncture, it's almost 37 or 38%. And so that lack of awareness that these two categories reflect is really the greatest reason for non-use compared to no reason, or feeling that they didn't need it, or that they don't believe in it. And interestingly, the category of not believing it is actually the lowest. Public folks are very interested in these, of all different backgrounds and so forth. So certainly awareness is key, and many people aren't aware of these therapies, not aware that they're offered in health systems, not aware of the evidence that may be related that I was just alluding to before. Now the availability. I used to, as the introduction said, I worked at Boston Medical Center, which is the main hospital affiliated with Boston University School of Medicine, and it is a safety net hospital. And so this is the city of Boston here, and the darkest green areas have a median have a median income that's higher than the median of Boston overall. So the median of Boston was about 53,000. So these areas have median incomes much greater than that, and then the light green here lower than median, and then these green areas are around the median. So I practiced at Boston Medical Center, and Boston Medical Center sort of in this area here, where there's a lower than the median income in Boston. And where do you see the availability of acupuncturists? You see them here and here and here in the higher income neighborhoods, and the neighborhoods where there's more median income. And you see a dearth or desert per se of acupuncture in these areas. And we've shown this for yoga, for massage therapy, and so forth. So we're talking about wellness disparities, which is the wellness status of an individual patient or community. But there's also a disparity in availability of these approaches and therapies. And this is what we worked on so much in Boston, to try to make these more available in these communities. The twist is, though, making a therapy available is certainly necessary, but it's not sufficient. So this is the greater Cleveland area that I'm circling here. And these colors represent neighborhoods within Cleveland and the crude rate of mortality from heart disease. And so this dark purple are the areas here where cardiac mortality is greatest. And if any of you are from Northeastern Ohio, the Lee Harvard area, Fairfax neighborhoods, North Shore, Bel Air, and Ruitas. Now, Cleveland Clinic, I'm not trying to brag or anything like that, but historically, up until a year or two, it was the #1 U.S. News and World Report Center for Cardiovascular Disease, and it's still one of the top in the top 5. And so the Cleveland Clinic is located right here. Right in this red circle area, where you see this very high frequency of heart disease mortality. This is not to imply Cleveland Clinic's failure on community efforts. We're working very, very hard on community efforts, but simply by having the hospital there, of course, we know that is good, is important, but it's not necessarily sufficient to bring about equity in wellness outcomes. Accessibility. I've done a number of studies looking at the use of yoga for chronic low back pain, various randomized controlled trials. And a number of them have been in predominantly non-white, predominantly low-income neighborhoods, particularly in Boston. And so these are some quotations we were able to obtain in our interviews with these patients. Things made it easier for me not to go because of my job. Sometimes they just reschedule the night before. So we are all very fortunate as professionals to have more autonomy and control of when we work in the clinic and when we don't. So we could schedule an exercise class, a yoga class or something, and feel pretty confident we'll be on it as long as we're not on call. However, if an individual is working a job where their shift can change day to day, they're really a required worker in sanitation, environmental cleanup, medical assistance, so forth, it's very, very difficult. And so that was one challenge in accessing. And then this person, in trying to come to the class, and these classes were in person, she wrote, sometimes I got a ride from a friend. If I didn't get a ride, I had to take 4 buses. And this is what, these are what our patients, face. These are the kind of challenges they face with coming to the clinic for us and coming and accessing therapies like in this case, yoga. But what we did is we tried to move out of the tertiary healthcare, referral hospital into the communities and offer these classes in the community health centers where they were used to coming in for their regular checkups to their family physician. And so they're much more amenable to coming into the classes. The other thing I just want to say is that many people thought, yoga in the Dorchester neighborhood of Boston, no one's ever going to do that. People are very amenable to doing that of all different backgrounds, races, ethnicities, ages, and so forth. And it's important that we dispel any kind of myths or implicit biases that we have about that. In the situation of chronic low back pain, there's a lot of suffering there, and they feel very often let down by the healthcare system, and the different treatments haven't helped. And so by offering something that may be of help, they were really quite, keen. And then lastly, of the 4 A's, affordability. And so this is Maslow's, hierarchy of needs. At the base, we need quality air, food to eat, water to drink, shelter, warmth, intimacy, love, sex, sleep. Going up the ladder, we need to feel safe, protection, security, law and order, limits, some stability. And then, of course, as we get higher, a sense of belonging and love with family, affection from our loved ones, relationships, our work colleagues, and then even higher, a sense of achievement, status, responsibility, or reputation, and then ultimately, personal growth and fulfillment. But some of the services historically, that I'm describing, or therapies, they're historically not covered by insurance or prohibitive without insurance, or if one doesn't have discretionary income. So these days, a yoga class in the community may cost $20, $25, an acupuncture session, $100, massage therapy, $125 to $150. And we've really led on efforts here to not only make some of the therapies which are covered by insurance, such as chiropractic, osteopathic, nutrition, holistic psychotherapy, acupuncture, covered by insurance, but also to set much more reasonable costs for these so that they're accessible. So this is the mission of our department, to be a catalyst and strategic partner across the entire enterprise to advance patient wellness, caregiver wellness, community wellness, and organization wellness. And so I'm just going to share 1 or 2 examples of how we're doing that, and happy to talk further. So we've tried to address these barriers of awareness, availability, accessibility, and affordability. We created strategic goals to increase and track the percentage of non-whites, the percentage of individuals on Medicaid or self-pay who are served by our group. And we also have strategically developed a plan to increase the number of community events, yoga classes, nutrition classes, fitness events, lectures in the community to be able to increase awareness, availability, and accessibility. And we've done this by strategically targeting clinics and hospitals or catchment areas where it is more likely than not to identify individuals non-white or lower income. We focused in on evidence-based approaches that are medically necessary. And so when I came to the clinic almost 5 years ago, the plan that Cleveland Clinic has to allow patients to receive free care if they qualified excluded some of these integrative services, and we were able to change that. Our services are in person, but also virtual, one-on-one, and then we heavily employ group visits, which we heard about in Dr. LaQuesta's approach. We embed services where there's an alignment of opportunity and evidence. So we have high evidence, for example, with stress disorders, helping pregnant women manage the stress that occurs, particularly in low-income populations. And so we bring prenatal yoga to those areas where there's that large need. We have many free resources that are web-based. We offer every year several hundred in-person community yoga classes, fitness classes, nutrition classes. And for these events where it is in kind, that contributes to the IRS 990 community benefit that Cleveland Clinic submits. So although it's not bringing in income or revenue per se, it is being documented as a benefit. And here are some examples. At the Langston Hughes Community Health Center, we have a wonderful setup of what's called Techno Gym, which is a great set of exercise equipment that remembers who you are, what your settings are, what were the number of reps that you did last time. It's a group environment. We have exercise coach there, and people feel a great sense of community and belonging, and it's a great help for weight loss. This is a wonderful ally of ours who has near the clinic a community garden, and we partner with her to offer these yoga classes in her garden over the summer. These are some of our gentle chair yoga that we offer at 3 or 4 different sites across Cleveland, again, focusing on sites where patients typically would have less access and less availability to these kind of services. And again, focusing in on group activities from an efficiency point of view, it's less expensive, but then you create this sense of joy and cultivate a sense of belonging. We run quite a few nutrition and culinary medicine programs. Culinary medicine is not just, nutrition is advising and counseling someone what to eat. Culinary medicine is showing them how to actually shop for the ingredients, prepare the ingredients, and cook them. And we do that with our teaching kitchens. And this is my older institution at Boston Medical Center, showing you some initiatives, a very large, robust food pantry, which we also have in Cleveland, and you saw in other areas of Ohio. And this is a rooftop garden where a lot of these vegetables are picked and actually feed the patients, feed staff, and it's also a wonderful area for school kids to become educated. I'll just close with this. This is a study that we just concluded called the Nourish Heart Study, and it incorporates that concept of food as medicine. And so this was funded by the American Heart Association, conducted by Dr. Hill and Dr. Amanda Shawcross. And we used 2 different interventions: medically tailored meals, where meals are prescribed for specific nutritional needs, in this case, cardiovascular disease, and they can address nutrition-related inequities due to access and availability. Shared medical appointments we've heard about, where we meet in a group, and it's a vehicle for socialized support for nutrition education and culinary medicine interventions. And so what the study did is we focused in on this community here of Warrensville Heights, where we have a hospital, we have outpatient clinics, and this is a graph of food insecurity, and you can see that zip code has some of the highest needs. And it was a pilot randomized controlled trial of 67 patients comparing just medically tailored meals versus medically tailored meals plus shared medical appointments with culinary medicine and actually cooking the foods versus a waitlist control. And the study was for self-identified Black individuals with one or more of the following cardiovascular risk factors: hypertension, type 2 diabetes, obesity, or metabolic syndrome. The data is not yet published, but I'll just share the Net Promoter Score, which is, on a scale of 1 to 10, would you recommend this program to a friend of yours? Medically tailored meals, 7.7, but the medically tailored meals plus a shared medical appointment, 9.4. And that's really, really awesome. So just to wrap up, wellness disparities, of course, are widespread. Wellness services and resource can contribute to wellness equity. They are not the solution, obviously. And the 4A's, awareness, availability, accessibility, and affordability, these are necessary to address these barriers, to implement and integrate these type of services into the health system and community. Thank you so much, for your attention, and look forward to any questions and comments. And I'll turn it over now to our moderator, Dr. Kristen Johnson.
Hello, everyone. So thank you so much. This has been an absolutely wonderful presentation. I'm so excited. So we got some really amazing questions, but we are running very short on time. So I did want to try to kind of hit the top question. So we'll start with Dr. LaQuesta. So we had a question come in that as a faculty member at a public institution, we've been limited in what we can do, excuse me, since Senate Bill 1, as well as other federal regulations. How can your practices be adjusted for public institutions?
Excellent question. So I'm sure that we've all heard of Ohio Senate Bill 1, the Advance Ohio Higher Education Act, which it really restricts curriculum around DEI initiatives. And so, there's a couple things. Number one, if anyone else has any ideas, I would love just go ahead and put them in the chat box, because we got a lot of smart, wonderful participants here who would probably like to collaborate on this answer as well. But some of the things that I was thinking about was, think about what the outcomes are that you would like to achieve, no matter what space it is that you're working in. Because, what are the outcomes that you would want to achieve out of a curriculum that maybe you're not able to present to your students, or not able to present to your learners, So, is it that social determinants of health exist? There's ways that you can, participate in the community in order to demonstrate, that educational tenet. Is it that, we need to use quality improvement in order to advance health equity? No one can argue with improved patient outcomes. So, as long as we're leaning on data and advancing patient care, Dr. Saper had a lot of excellent examples of, of research and studies that have been done that demonstrate the importance of health equity. And, you can't argue with data. And, knowing that those studies are out there and leaning on that information is going to be helpful during this time. And then another thing is, no one can argue with patient care. And the other thing is that, where you work is only part of who you are in your day, and it's only part of your impact of who you are as family physicians. And so, your 9 to 5 can look very different from your 5 to 9. And, you can support different initiatives, you can mentor, you can donate your time, your money, your resources. And so, this SB1 and those restrictions is only within a very small part of your area of power and influence. And I would inspire you to not get discouraged. And also, talk to your other fellow doctors that would like to advance in this space. Give us a call. Give us a call. We'll encourage each other and keep advancing the work.
Thank you so much, Dr. Cuesta. So I will use this as a shameless plug. We do have in the OAFP our work group, so you are more than welcome to come and help with the charge here, as well as learn a little bit more about how other people are doing this. In line with Dr. LaQuesta, I will echo that. I teach at Wright State, and so one of the things that I really wanted to make sure students got was that piece about what is the outcome, not necessarily us being able to have the conversation in the classroom. We designed a nutrition and lifestyle medicine course, and so the students have a challenge every month, and every month that challenge is different, and the students are learning that, you know, when I'm in anatomy, it is really hard to make better food decisions. Because I don't have time to cook. And like, what would it be like to be a patient who didn't have time to cook? And then I told them to just go cook. Or, you know, in other classes, maybe I had a little more time to focus on my stress relief, but like I'm really struggling in this space. So that tangible a moment of really looking at what is the outcome we're looking for, what do we want the students to take away, can be very helpful in having them to see what we're asking them to learn. So yes, thank you so much for that question and that answer. Dr. Saper, so we had a question about how do you perform these studies without a control? A lot of people were questioning, you know, what is our study design? And so tell us a little bit more about how maybe someone who was interested in doing this could maybe create like a quality improvement project or something to learn a little bit more about their patient population. And how you also control to verify your results.
Great question. So you're right on target. Some of these complementary integrative therapies are more or less amenable, certainly to a placebo or sham control. So here's one example of a very innovative approach. With acupuncture, investigators have developed a sham acupuncture needle. It looks like an acupuncture needle. It feels like the pressure, but the needle actually doesn't penetrate the skin. And so there are studies of RCTs looking at acupuncture for different pain conditions, arthralgias from aromatase inhibitors, so forth, that have used that control and has been very helpful. Yoga, there's no placebo per se. So you have several opportunities. You can compare it to another therapy like an educational book or physical therapy. And so what we did in our study in 2017, published in Annals of Internal Medicine, we compared yoga to PT. Why? Because we all refer to PT, right? It's reimbursed. We have a PT down the way. It's what we refer to for chronic back pain. So the idea was if yoga was as good as or statistically non-inferior to PT, that would be justification that it should be improved. And indeed, it was non-inferior. For a QA project, a great simple one is, create a survey for your patients, if yoga was offered in the clinic or in the health center, would you be interested? If yes, would you be willing to pay, $0, $1, $5, $10, something like that? And you can kind of go down the line, and that gives you a sense of the interest that's there, and then could potentially lead to a QI project, for example.
Perfect. Thank you so much. So my last question for both of you is what specific strategies would you recommend family physician use within their spheres of influence to advance health equity? Like a specific strategy that they could start using right now today, whether there's someone who's been doing this for a while or someone who is listening to this, has been inspired by your wonderful words and is like ready to do something, but has no idea where to start.
Dr. LaQuesta, do you want to go first, or?
Sure, I'll go ahead and go first. So I think something that you can do right now is to, think about, what community partnership can I collaborate with? I think that a lot of times people feel overwhelmed thinking that they need to initiate something de novo, start something from scratch in order to have an impact. when really it's, there are so many wonderful community partnerships out there that are looking for volunteers and physician volunteers, to help fill those gaps, to provide patient care, resources, education to the community. There are so many things that we can do right now, and those programs already exist. So the one thing that I would say is to, leverage your community partners, and that's something that you could start doing, right now. You could get on your smartphone and start Googling for, something that really speaks to your heart and is part of your passion, and also fills a gap that you see within your patients to address either their social determinants of health, or to advance equity in other ways.
Great. Well, I could give many examples. I'm just going to focus on two. Our patients, particularly facing all the stresses that are in society right now, experience a lot of stress. And I use the word stress a lot. Obviously, we also inquire about anxiety or depression, but stress is a word that everyone can relate to. So I ask people, how's your level of stress right now? What's causing your stress? How do you manage stress? And I will teach them right there in the office a very simple breathing technique, and it's called the box breath. And I can put a slide in a minute on the screen, but basically you have the person inhale slowly for 4 counts, hold the breath for 4, exhale for 4 counts, and then pause for 4. And then you do that cycle 3 times. It activates the parasympathetic nervous system, and it is remarkable. It just takes about 60 seconds, but some of our patients have never experienced a sense of relaxation. And so this can profoundly, impact mental health. My second suggestion is along the lines of Dr. LaQuesta, and it's the concept of social prescribing. Many of our patients, particularly older ones, but not necessarily, feel socially isolated, lonely. And this really is driving, their depression and challenges in managing their health. And so, in your own unique areas where we live across Ohio, identify 2 or 3 community agencies that can help link people. Yes, of course, we link people to, housing, food, but specifically to opportunities where they can volunteer, where they can take a class, where they can learn something new. And I'll put in my deck a couple slides with suggestions for Columbus and Cleveland. The United Way 211 line, that has some statewide volunteer directories. And so this concept of we prescribe a social intervention is actually policy in the United Kingdom, and it's been shown in studies to lower ER rates and primary care utilization and so forth. So this creating connection for people can be very helpful. It's easier said than done, of course, but many patients are amenable.
Wonderful, wonderful. Well, thank you both so much for your time this evening. This has been an absolutely wonderful webinar, and I know that our attendees and those who may watch this recording have gotten some excellent pointers as well as education from you. So thank you both for your time. I'll now turn it over to Erin to lead us out.
Thank you. Thank you. Thank you all for all of your wealth of wisdom. We really appreciate it. And I appreciate Dr. Johnson offering the questions and running through those things. I hope everyone enjoyed this session. I know we covered a lot of material. We thank you all for joining us today and are grateful for those of you who continue to participate in OFP programs. On behalf of the Academy's leadership and staff, we hope that we provided valuable education. Thank you for all that you do to advance health in your communities. Keep up the passion and the dedicated work. We really appreciate it. And thank you all for being on here. Thank you both, all 3 of you, for joining us tonight. We appreciate it.